Hello everyone, and welcome again to my YouTube channel. My name is Carlos Pedret, as you know, and today we're I'm going to try to explain a quite particular injury. But to understand this injury, the first thing that we need to ask is if we really know how the rectus femoris muscle works and which is its architecture in terms of muscle contraction and muscle function. Let's present the case first of all. The 20 years old professional football player, German international midfielder. So as you can see, it's not that guy here. Um, no previous injuries, no interesting risk factors. During a kicking mechanism in a training session, he felt an immediate pain in the anterior part of the thigh. He had to leave the training session at 24 hours more or less. The pain was moderate at contraction, stretching, and palpation, and he was unable to try an eccentric maneuver. MRI was performed within the first 48 hours, which is the main the time in which an MRI is the best time for doing it. And ultrasound was performed 1 week after. One problem that we have with that guy is that he felt really good in less than 1 week, which this is a big problem for doctors in the team, because the patient wanted to play, wanted to train, but as you will see, it's quite an important injury to let him play. Let's see. Let's look at the images. We performed the MRI first. Let's look at the coronal T2 scan. We're moving from the hamstrings to the rectus femoris. So we will look at the images starting from now. Here is the femur, as you can see. Now it's starting to define the rectus and the quadriceps complex. And you can see here in the rectus femoris that something is happening. Look here. Yes. Okay. Let's look at the axial T2. You can see here what's happening. Yes, it seems that the central tendon of the rectus femoris can be observed during all the trajectory of the scan, and at the end of the muscle there is a small liquid here, quantity of liquid here. So if we make a summary of the images, we can see in the coronal aspect that we have a central tendon that it's quite correct. You can see here that it's a little bit retracted, this attachment in here, but there is not a rupture. We cannot see a rupture in that central tendon, and we cannot see a rupture in the fibers attached to that central tendon. So it seems that a full muscle complex inside the rectus femoris has been disattached from another one. Let's look at the axial T2 scan and look at the surrounding rectus femoris here. The peripheral muscle is normal and the central tendon is quite normal. The fibers attached to that central tendon, yes, of course, we can see edema, but we can see that they are quite correct. And the problem is surrounding all of these fibers attaching to the central tendon. We performed the ultrasound scan, and as you can see, as we said before, look here, the problem is between that central region, central portion, here you can see, and the peripheral rectus femoris muscle. So this is a degloving injury. It's been described in the literature. We will see it now, but this is a degloving injury. But what do we understand what we say when we say that this is an intramuscular degloving injury? Let's look at that point. In 2014, Kasarjian et al. Published this article trying to describe this kind of injuries. As you can see in this schema, and it's quite similar to what we saw in the images, we can separate the rectus femoris between an inner central part and a superficial muscle belly or peripheral muscle belly. This injury, the intramuscular degloving injury, is the inner bipenate muscle component, the fibers attached to the central tendon, are disattached from the superficial muscle belly, from the peripheral muscle belly. So the thing and the problem is in that interface here, as you can see. So it's not the problem in the rectus femoris. It's not the problem in the central tendon or the central aponeurosis. It's not the problem in the fibers attached to that central aponeurosis. The problem is between this inner muscle belly and superficial muscle belly. So this pink area is disattached from this brown and dotted area. This is why sometimes we hear the expression that the rectus femoris complex acts as a muscle within a muscle. So obviously, if we go to the cadaver, we cannot see two different muscles, but we can make a differentiation in terms of injuries, that some injuries affect that region inside, some injuries affect the peripheral region, and the degloving injury affects the transition area between the inner muscle belly and the superficial muscle belly. Some more things to take into account in the intramuscular degloving injury. The age. In my experience, for example, I have seen several of these injuries during last 2 years. I have seen quite a lot. And you can see the same as in this article that it is more prone in young patients, in young football players in that case. And the mechanism, it's kicking. So it's the same mechanism as older players gets the central tendon injury. But in younger players, they are more prone to do that kind of intramuscular degloving injury. So that is a point that we need to take into account also. And obviously, we need to differentiate also the degloving injuries from the typical septal or paraseptal injuries. Here we have a paraseptal injury. So it's very different of what we see about intramuscular degloving injury. So this injury was described by Cross in 2004 as a bull's eye image in MRI, but after the Lord of the Rings trilogy, it is very much similar to the Sauron's eye than to a bull's eye. This is a paraseptal injury, quite well defined. We will see in the ultrasound. Look that in that video, in the transversal scan, that we can follow the central tendon during all the scan, better or worse, but we can see it. And look at the longitudinal scan, which is very spectacular in my opinion, and very revelative, because we can see the central tendon during all the trajectory. I will put it again. Look at the central tendon. Obviously, the problem is paraseptal. It's the fibers attached to that central tendon that are completely torn. Yes. And I put it again because I want you to take to be aware of that superficial muscle belly, that peripheral muscle belly that we were talking just before. It's completely normal. So this is a paraseptal injury, and this is why we say sometimes that this is a muscle within a muscle. So as a conclusions to that case and to that specific injury, we have to say that in an intramuscular degloving injury, the inner bipinnate muscle belly is separated, is disattached from the superficial unipinnate muscle. And you can see sometimes, or most of the times, an hematoma between, due to this disattachment, the space in the distal part is an hematoma, as you can see in the axial T2 scan in the MRI of the case I presented. At the most distal part of the injury, there was an hematoma there due to the disattachment. So this is not a central tendon injury nor a paraseptal injury. The pathophysiology remains unknown. We really don't know. We can imagine. I can figure it out what's happening there. Probably it's due to the maturation of tissues that older players, while kicking, they torn the central tendon or a paraseptal injury, and younger players just make a degloving injury in some of the cases. But we really don't know the pathophysiology of that kind of injury. In my experience and what I saw during last years, and the same as in the article I presented, the, the, the incidence is higher in young players, and the healing process, although it's not an intramuscular injury in terms of healing, is faster than a central tendon injury or a paraseptal injury. So here I want to clarify this point a little bit, because we talk about the intramuscular degloving injury, and probably we can say that this is if we have to classify that injury, it's an intramuscular injury. So we know that intramuscular injury are very mild injuries, but not in this case, because this is not a disruption in a muscle fiber. It's a disattachment from one part of a muscle from another. So it's quite a severe injury, but not at the highest at the rate of a paraseptal injury or a central tendon injury. And the treatment is always conservative with physiotherapy treatment, and it can go for from 3, 4 to 6 weeks, more or less, depending on the affection, depending on the hematoma, and depending on the treatment, of course. So that's it. About the intramuscular degloving injury. I just wanted to present you that injury and make you think a little bit about this kind of injury that we can find also in the anterior part of the thigh. So if you find this small review or small reflection useful, please do the like, subscribe to my channel, or leave a commentary there. I try to answer all the commentaries about your experience in this kind of injuries, or if you see it also in younger players, or whatever you want to say. Thank you, and see you soon again.